diastolic volume index when carvedilol is compared to the placebo. And when the ejection fraction is concerned, as I already told, there is over the period of time, the ejection fraction also increases. So the clinical problem solving, the different profiles. Now, what are the different profiles of the beta blockers as compared to the ivermectin? Heart rate reduction is definitely there with the beta blocker, and that can go to a significant low level and resulting in the side effect or reduction in the dose. Whereas the ivermectin, it does not go too much low, so that because if it is only on the sinus node, so there will be no significant decrease in the heart rate. Stroke volume reduced by the beta blocker, as you all know, but the ivermectin rather increases the stroke volume. Cardiac output, it is reduced by the beta blocker, so the neutral effect with the ivermectin. And blood pressure, there is no change in the blood pressure with ivermectin as opposed to the beta blocker where there is reduction in the blood pressure. Now, facilitating the up-titration of the dose of beta blocker, as I already told, that when you use only the beta blocker and patient cannot tolerate it, you cannot achieve the target dose or the recommended dose, then you have no choice but to reduce the dose to the maximum tolerable level. And on top of that, if you find the resting heart rate is more than 70, then you add the ivermectin to control the resting heart rate below 70 to get the maximum benefit of the combination of these two molecules, that is carvedilol and the ivermectin. Now you see from the slide that when ivermectin is used with the beta blocker, particularly the carvedilol, then the 19% without the beta blocker see the quality of the life, 19% improvement, and when the beta blocker is added with ivermectin, there is 80% improvement in the quality of the life because of the less side effect. And among the beta blockers, you see the blue bar showing that with the maximum benefit among the beta blockers with the carvedilol when the quality of life is concerned. The effect of the early treatment of beta blockers with ivermectin versus the beta blocker alone in the patient hospitalized with worsening heart failure, it is a randomized ethics study, and it has shown there is a greater improvement with the combination than the drug being used alone, and the better reduction of the BNP as well when the combination is given. Complementary prognostic benefits combination of carvedilol and ivermectin has been shown in the SHIFT trial that there is a 20% relative risk reduction with this combination as compared to the carvedilol alone. And also you can see the cardiovascular death or hospitalization from the heart failure or heart failure hospitalization, they are mostly in favor of the combination than the carvedilol alone. Now 2060, the ESC guidelines for the diagnosis of treatment of acute and chronic heart failure, the patient symptomatic heart failure with reduced ejection fraction, the blue bar, that is class 1 indication, is the beta blocker. We all know that. Now still the patient is not relieved, the ejection fraction is less than 35%, then you add the other drug, that is MRA, mineral receptor antagonist, which that is also class 1. The symptomatic, the low ejection fraction, what you do, then you have to go for another molecule that is again coming, the patient is in sinus rhythm, that is very important, and then you give on top of that ivermectin to improve the outcome. So that is how you add on therapy when you get a case of heart failure with reduced ejection fraction. Now coming to the anti-anginal choice on the top of beta blocker again in a heart failure setting, there has been seen there is no doubt that class 1 indication is the beta blocker, but again the patient is not totally relieved from the anginal pain, and now on top of that you can now add the ivermectin, which is a class 2B indication. Other anti-anginal drugs which is commonly being used like nicorandil or ranolazine, etc., they are all come under the purview of 2A to 2B. And still the angina persists, finally you go for revascularization. So management of heart failure with reduced ejection fraction, the role of carvedilol and the ivermectin is in the forefront. Heart failure has defined the ejection definition by the ejection fraction, whether it is low, whether it is mid-range, or with the preserved ejection fraction. So probably in the days coming, we may have the different definition of the heart failure. Heart rate modified risk factor, we can modify the heart rate. All beta blockers, probably carvedilol may be superior because of the ancillary effects. Ivermectin reduces the risk when the resting heart rate is more than 70, and it is possible to combine these two to help in the improvement in the quality of life, recurrent hospitalization, and improvement in the survival, and facilitating the up-titrating dose of the beta blocker. So the important point is to note that heart rate is dysregulated by genetic background. It is a neuroendocrine manifestations. It is not a physiological reaction to support the cardiac output. So the target should be around 50 to 60 and thereby improve the overall ejection fraction and the survival benefit. Thank you for your kind attention.
Thank you, Dr. P.S. Banerjee, for your beautiful presentation. In fact, both the speakers have done excellent job in giving deliberation on two topics, that is the SGLT2 inhibitor in heart failure with reduced ejection fraction by Dr. Rakesh Yadav and Dr. P.S. Banerjee on ivabradine carvedilol combination. Now, as you know, the most important concern in the heart failure management, or rather heart failure with reduced ejection fraction management, is the recurrence of heart failure hospitalization. Now, since that can be reduced by both the drugs, as it has been highlighted by Dr. Yadav regarding the use of SGLT2 inhibitor in addition to the treatment with various other drugs, as the diuretics, then ARNI or ARB, then beta blocker, then MRA, and over and above that, the SGLT2 inhibitor has come in a bigger way to prevent the recurrence of hospitalization, as well as the mortality, as well as the MACE. Same way, the very interesting part of the beta blocker story in heart failure is the use of the non-selective beta blocker like carvedilol vis-a-vis the selective beta blocker like the metoprolol as well as the bisoprolol. They are giving, it is giving more beneficial effect in terms of reducing the MACE. And when you are combining the ivabradine to reduce the heart rate further without jeopardizing the hemodynamics, you can actually gain more benefit. So it's a very interesting combination. Now, the first question I would like to, we will be having some
Let
discussion.
us get the comment from Dr. Deb. You
Yes.
want to put some comments?
Oh, yes, maybe a small comment.
Unmute
I want to
yourself,
know, in fact,
Gilda.
I want to know from Dr. Rakesh Jadhav, how in a non-diabetic patient, the SGLT2 inhibitors becomes an heart failure modifying drug. And to Dr. P.S. Banerjee, I want to know if the heart rate is at below 70 with beta blockers, will you advocate administration of ivabradine?
Sir, your first, the answer of your first question, how in non-diabetic? Probably what I feel that it has a diuretic effect. There's no doubt about it because it causes glycosuria. Second important thing, this in non-diabetic, it is a subgroup analysis. Basically, they have initially included pre-diabetic in a non-diabetic. So it may be possible, and there's a lot of debate on that, but the subgroup analysis may sometime be taken as a pinch of salt until they do a strict randomized trial in a strictly non-diabetic patient. The answer will not be there. So it's basically a subgroup analysis. So the probable action which has been mentioned in this situation, that probably the renal glucose toxicity is less, you will have a diuretic effect, you have more sodium excretion. So probably these may be the mechanism. And there's one, if you go to the net and see the counter of this trial, they say in placebo you should have increased the dose of diuretic. So if you have increased the dose of diuretic in placebo and then if it shows benefit, then you can really understand that it is beneficial because it is.
But can you recommend anything on the basis of subgroup analysis?
If you ask me at present, if it's a diabetic and pre-diabetic, I will give it. But in a non-diabetic, I personally have not started
FDA has approved it, don't worry. FDA has approved it for non-diabetic, and you have non-diabetics also. And you have shown a slide which shows HbA1c 5 to 6. So that is not pre-diabetic more. So I think right now we can, and I do agree, there are no dedicated, isolated diabetic studies.
You have still said can. In a diabetic and pre-diabetic, I think it should be a first-line drug. And now it is a cost-effective. Initially, it was not. There's a lot of debate of cost-effectiveness, so very costly. So at present, I think if it's a pre-diabetic and diabetic, SGLT2 should be given to all patients. In a non-diabetic, it depends upon your choice. If you want to give, there's no harm in giving this.
I think regarding this particular issue in the non-diabetic patients with heart failure, there is no doubt that the DAPA heart failure trial has adequately shown when the slide was showing the HbA1c level, irrespective of the HbA1c level, the results were quite efficacious in case of the dapagliflozin use. So there is no doubt that it can be used in the heart failure without even diabetes. And in addition to this, actually, there are few other good effects of the dapagliflozin in terms of reducing the obesity. This is a very, very important marker of increased mortality in heart failure patients. And this has been shown to be very much effective in reducing the obesity or the weight. And that weight reduction also helps in terms of reducing the MACE. So I think it can be used even without consideration of the diabetes mellitus.
The real mechanistics of SGLT2, we don't know honestly, because since you brought in obesity, there is an obesity paradox in heart failure.
Yeah.
Patient with
No,
obesity do better in heart failure.
That can be.
No,
But
So-
one
No,
very
Dr.
interesting
Jadhav, Dr.
Yes.
Jadhav, just last question. Say a heart failure patient, non-diabetic, he has got an appropriate dose of diuretics, beta blockers, ARNI, and aldosterone antagonist. Now he needs the help of another drug. Which drug you are going to choose? SGLT2 inhibitor or ivabradine?
No, if the heart, you are telling optimal beta blocker, it means heart rate is controlled. I will definitely choose SGLT2 inhibitor in non-diabetic. But if you say me diabetic, at present, what I have read, I will add SGLT2 with even a low dose of beta blocker and ACE inhibitor. But in a non-diabetic, I will first optimize this drug and then I will add SGLT2. This will be my practice.
See, well, at least if you look at the data looks much more impressive with the SGLT2. See, 35%, 40% rate hospitalization rate reduction. You can never achieve that with an ivabradine. See, ivabradine is useful. Whatever we say, ivabradine combination, we know shift has 90% on beta blocker, but 50% was on target dose. So the advantage of ivabradine has been over the non-targeted dose of beta blocker. Correct me,
Yeah.
sir.
The point what Dr. Dev was talking about, the addition of the ivabradine when the heart rate is below 70. You are talking about that?
Yes,
No,
yes,
that,
yes.
as I already discussed, that the main agenda is to reduce the resting heart rate below 70. So if you can achieve that heart rate without any side effect of the beta blocker or any hemodynamic compromise like reduction in the blood pressure or reduction in the peripheral perfusion, all these things, then I don't think in the control heart rate with the tolerable adequate dose of beta blocker, you don't require to add ivabradine on top of beta blocker.
May I have a comment?